So just wanted to acknowledgements and disclosures real quick. I wanted to highlight thanks to the Parkinson's Foundation and really specifically Annie Brooks and Annie Long and all others who helped put this together, and Martha Ann Tudor as well, just being really instrumental in the organization and making sure that this presentation could be put forth for you all. No conflicts to disclose, so we'll keep going. So today, a couple of things that we're going to talk about. We're going to define culture as a concept and talk about what does it mean to define our own cultural identities. We're going to compare and contrast the difference between cultural competence and cultural humility. We'll identify some unique cultural factors of LGBTQ identity, Parkinson's identity, and the intersection of both, which other presenters have also covered really fabulously. And finally, describe how do we practice cultural humility in our work with patients and care partners and in our own lives. So culture is a lot of different things. And I think when we first think of culture, certain things come to mind, right? It's holidays like Christmas or Cinco de Mayo. It's food. You know, we think of what is Indian food versus other food cultures, games, language, Spanish, English, right? And this is maybe some of the stuff that immediately comes to mind when we think about culture. But in reality, this concept of a cultural iceberg, it is so much more than just these things. That culture is also the way in which we communicate, the rules we have, even if we're not conscious of them, about eye contact, about being close to someone or even touching people. It's ideas about courtesy and friendship and cleanliness and beauty. How do we approach our elders? How do we approach physicians versus nurses versus other patients? How do we think about death and what it means for us? And how do we approach decision-making and how that decision-making relates to those around us? And these are all things that, even if we don't think about it, are showing up constantly in our lives, and particularly so in healthcare and the ways we interact with those around us as we receive our healthcare, as we provide healthcare, and as we make choices about our healthcare. And so just as we go through this, I would encourage you to think about all the different ways that culture shows up in your life and all these different experiences you have with healthcare and going, well, how does culture play a role in that? When we talk about identity, there's this fabulous model called the addressing model, and it really covers a broad spectrum of identities, but it's not the end all be all. Addressing stands for age, disability developmental, so disabilities that we may be born with, like intellectual disability or ADHD, but also disability acquired, which we might consider Parkinson's to fall under, but we'll talk about that later if you do consider that a disability. It's things like religion and spirituality, ethnicity, socioeconomic status, middle class, lower class, upper class. Of course, sexual orientation being relevant to our discussion today. Indigenous heritage, national origin, and gender. And so, again, this is not comprehensive, right? But this is many ways in which we have different identities, and the bubbles on the right also show other ways in which identity and culture shows up in our life, our political affiliation, our job, our education, our marital status, all things that we've been talking about today. So I think it's important, as your presenter, to state some of my own identities. I'm 30 years old. I don't have any developmental or acquired disabilities. I was raised Catholic, but don't really identify with a religion now. And I'm already finding I'm still finding new ways in which that influences me. I am white and of a upper to middle class socioeconomic status, identify as gay and not of indigenous heritage. I was born in America and still live in America, and I identify as male. And I feel it's important for me to state these, not only to give examples of how we apply these identities, but because this is the frame and lens from which I'm discussing these topics today, that I am a gay male, but it doesn't make me the expert on all the LGBTQ community. I don't have Parkinson's, but I do work with Parkinson's patients. I come as a psychologist, not a physician. And so just taking a chance to reflect on your own identities and have they evolved over time, right? I highlighted that I was raised Catholic, but I'm not Catholic anymore. And that, that influences things for me. So just think about how all these different identities influence the way you see the world and the way your cultures show up in your life and the lives of your patients and care partners. So these ideas of cultural competence and cultural humility. Cultural competence is something that is I think, thankfully getting more infused throughout healthcare. And this understanding that to be culturally competent, we have to gain cultural knowledge. We have to know cultures different than ourselves. What are they like? What strengths do they bring to the table? And we also have to develop cultural self-awareness, something we're doing already today about what is my own culture? What are my own identities? And how does it influence the way I view and interact with others? But a more developing topic, and one that I hope continues to get infused throughout healthcare, is this concept of cultural humility. So cultural competence is a foundation, it is necessary, but to be culturally humble means that we acknowledge systems of power and that we are willing to hold those systems accountable, that it is not enough to just know that people of color experience racism, that LGBTQ people experience discrimination, but to understand that those discriminations come from systems, that they are infused into our society, they are infused into our systems of healthcare, and that we have a responsibility from whatever perspective we come from to try and address those power imbalances. How can I use my own understanding of my culture? How can I use my understanding of other cultures, this foundation of cultural competence, to address these power imbalances? Cultural humility ultimately is about recognizing that we don't know everything and that we can build a strong foundation of cultural competence, but in reality, we have to be humble in the way in which we approach interacting with those different than ourselves. And we have to be humble in approaching our own identity paths and go, I have more to learn all the time, and that's okay. And I can come to the table best as I can. And we do that through developing a desire to know culture better, through practicing skills that help us communicate and interact with cultures different than our own, and to ultimately engage in encounters, to not just build the knowledge and the skills, but then to go forth and interact with others different than ourselves. And doing this over time is how we continue to build cultural competence and cultural humility. So just wanting to talk briefly about some cultural factors that relate to LGBTQ identity. Being LGBTQ is an umbrella. So this umbrella down in the bottom right corner, queer is a term that many individuals may associate negatively to say that someone is a queer or is acting queer, but it's been a term that's been reclaimed by much of the LGBTQ community, that it is a very umbrella term to represent the entire, as Dr. Esfold said, alphabet soup of labels, of which there are an infinite number, constantly expanding. It's hard to put a number on it. And that this encompasses both sexualities, being lesbian, gay, bisexual, others like demisexual, sapiosexual, pansexual, but it also encompasses gender, being trans, being non-binary, and that these are not the same things, but they are all one big community. And I think that's important to highlight because unfortunately, there are people in the LGBTQ community who say, well, we don't want the T part, we just want the LGB part. And we can't do that. We have to be a family. So it's important to recognize that we all fall under this umbrella, but they are diverse subcultures. They're not a monolith. And that the experiences of a gay man is different than the experience of a lesbian woman. The experience of a bisexual individual is different than the experience of a non-binary individual. And to recognize that those experiences can be different, and not presuming that just because you've met one gay man like me, that my experience and my behaviors and my life is the same as another person, right? It's important to also note, and this was in our last presentation so well described, that LGBTQ people experience significant health disparities. There are much higher rates of illness for the LGBTQ community. LGBTQ individuals are 2 times more likely to experience mental health difficulties. They actually, it's 3 times because they're 2 times more likely to experience substance abuse difficulties. When we look at rates of domestic and interpersonal intimate partner violence, for example, the rates are often much higher, and those are much higher specifically for bisexual people rather than gay or lesbian people. Trans people in particular experience some of the worst disparities in terms of discrimination, abuse, suicidality. And the problem is, beyond just that they are experiencing these things, that there are lower rates of healthcare access, that LGBTQ individuals are less likely to have proper health insurance, to have adequate health insurance. They are less likely to have, access to individuals who they feel are understanding and competent and humble about their identities and their culture and their needs. And they are less likely to access that healthcare. It's not just a matter of having it. They may live in a community like Augusta where we've got, some decent resources. We're no Atlanta or New York, right? But we have resources, and yet I don't feel like I can go even access that healthcare because I've been discriminated against, because I am afraid to leave my house because of my identity, right? But it's also important to say that these health disparities are not because of identity. They are because of societal discrimination. LGBTQ people have higher rates of mental health, not because something is inherently wrong with them, but because they are discriminated against by a society that is heteronormative and cisnormative and treats LGBTQ people as an other. And this is getting better, but it is not perfect by any means. And unfortunately, we're seeing some slide back, at least here in America. And we know this is true because when we look at things like rates of acceptance, for example, trans children have an enormous high rates of suicidality. But the number one thing that predicts that those things are not present for trans kids is parental acceptance. And so it just goes to show that there's nothing inherently wrong with these kids. It's because when they feel loved and accepted, of course, they love and accept themselves and are less likely to experience mental illness. Lastly, one thing I want to cover is trans broken leg syndrome. So this is a term that means basically, I tell it often as a story. A trans individual comes into the ER and they tell the doc, they get admitted and everything. They're in a room and the doctor comes in and says, "Well, what brings you in?" They said, "I broke my leg." And then the doctor goes, "Well, I notice here on your chart it says you're trans. How do you think that impacted your broken leg?" It doesn't. Their leg is broken. And unfortunately, we have sometimes a tendency to put everything in this umbrella, and it's not. LGBTQ people are ultimately people who experience the same health difficulties that many non-LGBTQ people do. And so it's important to hold in balance that queer identity does have an impact on health, but it is not the end all be all. A broken leg sometimes is just a broken leg. Ultimately, queer people have pride. I'm highlighting the disparities that queer people do experience, but it's important to note that the number of queer people in our communities is increasing. And that's not because there is some conversion happening or we're making people that way. It's because people have always been this way, but they finally feel, again, safe and open and accepted and understand that they can hold these identities and be a part of a community. And so it's important to not just go, "Oh man, all these queer people are having so many difficulties." They're fabulous. This is a fabulous community. I'm so proud to be queer. And I hope you can share that with your patients, that you can share in their joy of being queer. Attend Pride. It's coming up here in June. Be visible in your communities to support those LGBTQ people, even if you aren't. When we talk about cultural factors of Parkinson's, this is something that's a little less studied. I did try and do some examination of research studies out there and things that maybe kind of say, what is the culture of Parkinson's? A couple of things I did find. That often when it comes to Parkinson's and neurodegenerative illness, we hold the stereotype of older, affluent white males. And this is not 100%, right? But when we look at the individuals that are very forward-facing around Parkinson's in our culture, people like Michael J. Fox, Davis Finney, these are older, affluent white men. And so it can, whether we know it or not, create a picture in our head of, oh, this is who gets Parkinson's. And yes, there is some truth to the fact that Parkinson's tends to show up later in life, but it happens to all kinds of people at all kinds of stages of life. And so when we hold a stereotype in our head of, oh, this patient is in their 30s, it changes the way we interact when we're expecting them to be 60. Of course, there are exceptions, right? Muhammad Ali, as a famous example of someone with Parkinson's, but Muhammad Ali, passed away many, many years ago and is maybe not the person we think of first. And so just keeping in our head, what image do I have of a person with Parkinson's? It may look different than this one, and that's fine. But just knowing that whatever image you hold is going to show up in the way you interact with patients. and interact with others with Parkinson's. I know I'm speaking a lot today kind of from a provider perspective, but I want to acknowledge those who are present who are not providers, who are our patients and their care partners. And Parkinson's can be an identity and culture in of itself, that when people get diagnosed with any chronic illness, Parkinson's is no exception, that there is this identity process that happens, that people start to go, what does this mean for me to have this label of Parkinson's? And do I accept it as a label? I mentioned earlier that disability as part of the addressing model, or acquired disability, some may consider neuro illnesses like Parkinson's to be a part of that. But it's important to remember that not everyone holds this label. Disabled carries a lot of weight. And in this country, disabled people are still treated differently. And we finally have some laws protecting them like ADA, but you have to know, does my patient view themselves in this way? There's this concept of the sick role, and it's from sociology, and I'm looking off to my phone because I took some notes that I couldn't pull up on my computer. And there's basically 4 ideas that we assign to sick persons. That sick persons are exempt from social roles. We don't expect them to do the things people who are not sick can do. That they are not responsible for their illness, and we often treat people differently when we think they brought this illness upon themselves. That they must try to get well. Illness is a temporary state. We don't view it in our culture as allowed to be chronic or permanent. And that sick persons must cooperate with medical care, and they must try to get well. And so considering, what do we hold? What ideas are in our head about individuals who have illness broadly? In this case, Parkinson's, a chronic neurological illness. And do we expect people with Parkinson's, whether they're in our lives, whether they're our patients, whether they're ourselves, how do we approach? Do we feel like they must get better? They must cooperate with medical care? That's not necessarily how every person with Parkinson's is going to approach their illness. Intersectionality is a concept basically meaning that our different identities don't exist in a vacuum, that we are not just gay, we are not just a Parkinson's patient, we are not just in older age. We are many, many, many different things, and that these identities and cultures that we possess intersect and interact, and that it looks different to be a gay white male than it does to be a gay black male. It looks different to be an older Parkinson's patient than it does a younger one. And often these identities intersect around power, that when we consider our society and culture, we afford a lot of power to people of certain identities, people who are married, who are white, who are Christian, male, straight, cisgender, right? And that people on the margins often don't hold these powers. And so we find that when people of multiple marginal identities intersect, that it's not necessarily that their difficulties compound. It's not a 1 + 1 = 2 situation, but that it looks very unique, and we have to be mindful of that. A great way in which this shows up, a great example, is access to resources. So in preparing for this, finding some resources from the Dave Finney Foundation that talked about this concept of, we may tell our patients to do certain things. We may say, you need to engage in healthy eating, right? But eating healthy is not always easy. Can you feed yourself? Can you even buy food? Do you live in a food desert? And do you have access to the resources you need to eat healthy? Do you know what that even means? And that all these different identities may influence a person's concept of healthy eating and their ability to engage in that. And we have to be mindful of that when we make recommendations to patients. Can you afford your meds? Can you afford to get DBS, deep brain stimulation surgery? Can you recover from that? In our panel discussion, it was such a wonderful thing to watch. And I really appreciated this idea of coming out as a concept that is really built up and researched and understood in the LGBTQ space. But in reality, we all come out all the time with lots of different identities. And that to come out as a Parkinson's patient requires vulnerability, disclosure, safety, and having other people adjust to view you in a different way than they did before, much the same as happens to be LGBTQ. And that coming out process happens over and over and over. You don't come out once, whatever your identity, and that's the end of it. You have to come out to people again and again and again. And for something like an illness like Parkinson's that is progressive, you have to come out repeatedly as maybe different statuses where you are at in the stage of your illness. And that is going to intersect with the other identities you hold. So as we work with each other, we work with ourselves and we work with our patients, we have to be mindful that people are not just one thing. They are many things, and those things interact with one another. So when we consider competence and humility, I want to lead you all in sort of a reflection exercise. I'm not asking at this point for you to turn on your mics and answer or even drop in the chat, but just to sit with yourself for a second as I walk you through some questions. First of all, are you aware of your own identities and the culture that goes with them? As we look at something like the addressing model, do you have difficulty identifying a particular identity that you have? Or is there any identities that you had not given thought to before? For example, Indigenous heritage or your nationality. Are you aware of the identities and culture of the people around you? And here I say patients and care partners as a reflection for our providers, but this goes for anyone. Do you know the people around you, what they identify as, or do you make presumptions based on the way they appear to you? Around power, are you aware of how others perceive you, your identities, and your behavior? And again, I word this as a reflection for our providers, but for anyone. Not only do you perceive others and make assumptions about their identities and culture, but your own is perceived. And so for our white providers, for our white individuals, you have to understand that you are seen that way and that people of color may approach you differently based on being as a part of a majority race. Are you aware of how you respond to others' identities? For providers, how you respond to your patients and care partners. For our patients and care partners, how do you respond to those around you and your response to their identities? Are you aware of the ways that you, the places you are, including your locality, your workplace, your homes, your institutions, are you aware of the ways in which they erect and maintain barriers that disadvantage patients? That by making patients jump through certain hoops or hurdles, they may or may not be able to access the healthcare they need. Are you taking steps to address these barriers, to empower yourself, to recognize the power that you have through your certain identities, to try and improve the barriers that others have? I think of one of my patients who, in their own pursuit of DBS, has been trying to tear down barriers that have made it hard to get scheduled. That is managing structural barriers. And lastly, self-awareness. Do you make being culturally humble a key part of your practice if you're a provider, or your life as any person? Do you recognize the ways in which you maybe fall short of knowledge, of humility, of competency, but being kind towards yourself and striving to do better? And ultimately, do you understand that all of us, myself included, even if I'm the person giving this presentation, need to keep learning? And are you aware of the ways in which you have to keep learning? It's a lot to think about. Here, I'm going to focus a little bit for providers, but again, I would encourage those who access healthcare to advocate for these things if you notice them in the places in which you seek healthcare. When we talk about visible materials, does paperwork allow for self-identification, or is it just limited to a few identities? Do we ask, what is your gender, as opposed to, are you male or female? And do materials that we put out there show a diversity of identities? Is the images that the hospital displays showing people of different ethnic backgrounds? Is it showing partners that may be queer? When we interact with patients and interact within healthcare systems, are we asking someone their identity, but then ultimately not respecting it? Or maybe checking a box by saying, what is your gender? And then we use the wrong pronouns. Is a care partner presumed to be a spouse or a friend based on gender? And this can be the case not just for queer people, although I think often, but for anyone that, oh, well, I know that Mrs. Smith is straight and she's got this gentleman with her, must be her guy friend. And it's her brother, right? Are we making presumptions? And does staff lead by example? And I struggle with this too. I don't often do this, I will admit. I have displays of visible queerness, such as the badge that Dr. Esvold shared, but even then that doesn't automatically identify me as queer or competent. I may have just strapped it on because someone told me to. Am I leading with, hi, I'm Dr. Kridel, I use he, him pronouns. What do you want me to call you and what are your pronouns? And is this environment present throughout our communities? We may create a safe space within one unit of a healthcare system, but then other parts of it are not the same. What about the transportation we call for patients to assist them with getting home? Waiting rooms? Do the ways in which we reach out to patients use accurate identifiers, but also safe? Are we considering that some patients may not be out in all environments? And so how do we make sure that when we reach out to communicate, we are not outing and sharing an identity that a patient may not have wanted to disclose yet? One of the last things I'll talk about is this concept of trauma-informed care. And I think this is a great thing to keep in mind, not just around LGBTQ identity, not just around Parkinson's, but in how we treat all people around us. That trauma is a bit of a buzzword right now. To use it loosely and not in the strictly medical psychological sense, trauma are things that have happened to us in our past that stick with us to this day. And often these things can be very upsetting. It's discrimination, it's violence. And understanding that when people are traumatized, that they may not feel safe in environments that we do, that they may not feel safe anywhere. And so how do we create an environment of safety? How do we acknowledge that people around us have experienced trauma and create a space that is safe for them to exist? That they may take, looking at these heads, they need space, including time, to pace themselves and calm down and react to a new diagnosis. That things need to be predictable. And in an environment like academic medicine, where you may see a different resident every time you come in, that can be really frustrating. That we want to give patients choice. It's not, you need to take this medication, but here are the options for you. What do you think? Ultimately, trauma-informed care means shifting from a concept of what is wrong with you to what has happened to you. To understand that all of us, had we gone through the same experiences another person has, may have ended up behaving and thinking and feeling in the same way. And to go, okay, I could say that my patient is non-compliant and unwilling to take their meds. Or I can say, there is probably something that has happened or is happening to them that makes it difficult. And that is worth exploring and addressing and accepting. So I know we hopefully have some time left for questions. I just want to say thank you. And I hope that, you approach this stuff with a spirit of self-compassion. It is hard work working around ideas of culture and identity. And so know that it is important, and know that as long as you are willing and humble to make changes and steps in your life, you are doing the right thing.